Okay, are we live?
No, just a few seconds. Right, we're live now.
Okay. Yes, thank you so much. Firstly, good evening, South Africa. Good evening, fellow medical fellow interns, fellow ComServes, fellow doctors, fellow specialists, fellow HODs. Thank you so much for gracing us with your presence and taking out this time and to just, be with us. I hope ESCOM will be on our side for you and for us, not load shedding for the next 2 hours, that we can have a great time of dialogue and conversation, and most importantly, come to solutions on how we can get rid of this monster and elephant that has been around our society for a long time. My name is Dr. Siviwe Mila. I'm a medical advisor at Proactive Health Solutions, which is a wellness company that mainly focuses on employee wellness and other stuff. So just how this topic, so sorry. Prof, you just had load shedding. Okay. So sorry, guys. Prof Glover just had load shedding. Yeah. So we'll just see how we can navigate around that and see if maybe she can quickly join us afterwards. The session is going to be 2 hours. The first hour, we're just going to be having our panelists share their experiences. And then after that, we'll have a question and answer time where we hope to address a lot of things and also just a bit of the study that went out. We've gotten great feedback. Thank you so much, South Africans, for taking time and filling it out. And it will just serve a lot. I'm just going to first introduce my boss, Dr. Fundile Nyati. He is a specialist in family physician, and also, yes, Prof can still hear us, although we can't see her. Thank you so much, Prof Lova. Dr. Fundile Nyati is a specialist medical physician. He's also the CEO of Proactive Health Solutions, and also in his spare time and his hobby, he usually calls it, he's a host of Dr. Fundi channel. So over to you, Doc. And after that, I'll just introduce our people. Thank you.
Thank you, Dr. Mila. Good evening to everybody who has joined us this evening. Evening to all the panelists. We've got, a diverse group of panelists. We've got a dean of the healthcare of a medical faculty, Prof. Glover. We've got the head of department of psychiatry at Stellenbosch University, Prof. Suraya Sidat. We've got Dr. Flavia Sankubuge, who is the president of the College of Medicine of South Africa. We've got Liesl Anthony, who is a private clinical psychologist who is finalizing her PhD with UWC. We've got Dr. Zolelwa Sifumba, who is a junior doctor who has just finished a ComServe last year. And then we also have got Dr. Right. So I said Dr. Zolelwa Sifumba, and then we've got Dr. Dube, who is a specialist neurosurgeon, so it's a wide range of people within the medical profession who will share their experiences. I just want to correct something that my colleague Siviwe mentioned. I am a family physician. I did family medicine. But anyway, so I've got two hats, that of being a medical doctor, but also that of being a business person. So I'm the CEO of Proactive Health Solutions. But today, I'm just the host to make sure that we have a conversation about this issue that seems to be a big elephant, in the room. Now, in 2019, the International Labour Organization did a study, and they found that 12% of workers worldwide, they experience verbal abuse, they experience humiliating behavior, they experience bullying, they experience unwanted sexual attention and sexual harassment. And a number of people experienced bullying and harassment, repeatedly. And what they also found was that workplace bullying was actually much higher within the higher education sector, between 32% and 65%. So whilst it's 12% in the general workplaces, but in higher education, between 32% and 65%. I think with that, it becomes clear that we have a challenge. And today we are specifically focusing on, workplace bullying in the academic sector, or even in workplaces in the healthcare space. There's a lot of reports that have been going around about people who have gone through this experience. It seems to be a culture within the medical profession, all the way from the undergrad, also up, all the way up, even when people are registrars and sometimes even consultants. Studies have been done. Just last week, there was a study that came out of the South African Medical Journal, which looked at bullying, amongst or to the registrars in psychiatry across all the medical schools in South Africa. And the findings there were not so good. And they pointed a big finger at consultants, and also there's another study that came out last month on the SAMJ, and that one was looking at bullying in the healthcare faculty at WITS. And even that, despite the fact that WITS has got policies against bullying, but the reality on the ground was different. So there's a number of studies that are coming out, but what is not coming out clear is what are the institutions doing to deal with this problem that has become a culture or a subculture within our profession, and what avenues are there for those who believe that they have been victimized. There is a lot of reports. There's a lot of reports that show that some people, even if they do report, but institutions would rather, sweep that under the carpet, because maybe the bully or the perpetrator is somebody quite senior within the organization, and therefore there's fear that if somebody reports them or takes them on, it may have negative consequences in terms of their career progression. So with those words, I just want to welcome everybody. Thank you very much for joining us. We have 2 hours of conversation about this particular serious issue, and hopefully it won't just be a talk shop, but we can be able to come up with something concrete that can be taken to a phase 2, where we can bring people like the Human Rights Commission, people like the Section 27, the HPCSA, the College of Medicine, so that we can say what needs to be in place to protect the various members of the medical profession, starting from undergrad all the way up. So with those words, thank you very much, and I'll hand over to Dr. Mila again.
Thank you so much, Dr. Nyati, and apologies for that. Okay, we're just going to have the program as follows. We're just going to have a few speakers in the panelist. Our keynote speaker for today is Professor Soraya Sidat. She is a psychiatrist, and she's also the head executive of the Department of Psychiatry at the Health Sciences faculty at the University of Stellenbosch. Prof, can I hand over to you? And also she's done a lot of research in this topic. Can I hand over to you, Prof? Thank you so much.
Yes, thank you. Are you able to let me share my screen?
Okay, let me try and do that, Prof. Sorry.
Yes, we'll just get our technical guys to fix that. Thanks.
Yeah, let me just try and do that quickly.
So good evening. It's a pleasure to be able to speak to you this evening, and it's also a welcome deflection from the COVID-19 pandemic, which has cast the spotlight on both educational and occupational wellness. And as Dr. Nyati has said, bullying and harassment remain an epidemic, but in fact a silent epidemic within medicine. And while most of us know that bullying in the workplace is unprofessional conduct and that it's reprehensible and wrong, we are, I think, collectively to some extent to blame for allowing it to continue as medical professionals, as clinicians, as educationalists within the academic medicine workspace. Like many of you, I, many decades ago, as both a medical student and as a registrar, had my own experiences of being belittled and humiliated, initially as a medical student and then as a registrar. And I failed to report those experiences. I accepted them as part of the culture of medicine, as part of the confrontational nature of teaching that existed within medicine. And in fact, it was only a few years ago, 5 years ago, when this doctor placed her YouTube video detailing her experiences of bullying that...
My name is Yumna Musa, and I want to tell you why I don't want to be a doctor anymore. Last year, I worked under a man who sexually harassed me. It wasn't only me, it wasn't always sexual, it was open, and it was every day. Humiliating and degrading lower-ranking doctors is a big part of medical education. So he is an award-winning teacher. I had to say something. I had my phone with me while the hospital management explained that actually there was nothing wrong with my supervisor's behavior. First, the racism.
Are you defining yourself as colored?
Well, it's tricky for me. I don't want to.
But no, you're saying that this is a racist problem. So you must pick a race, and then we work from there. In the last 2 years, as far as I can see, there have been 16 whites, 42 Indians, 33 blacks, and 10 colored, of which there's one I'm going to classify you as colored, whether you like it or not. In this diverse group of people in your group, he must have experienced the same process because he's part of, he's a colored, he's in the department of.
So following on that video, I was horrified and had a few conversations with medical students at the time. I think I'm going to have to go out of the presentation. Let's see if I can get back. Apologies for that. I had a few conversations at the time with medical students at my faculty, and shortly after, together with the medical student, embarked on a study. But what I plan to do today is to very briefly highlight the issues of workplace bullying, to define the scope of the problem that currently exists, to highlight why this problem exists, why it's continued to exist, what are some of the drivers and risk factors for bullying, harassment in the workplace, how does it impact medical students and doctors, and more specifically, what are the mental health impacts, and what should we be doing to stop it? What are some of the prevention mitigation strategies that we can put into place in our own workplaces? So workplace bullying has been more recently defined by the American Medical Association as follows. And I won't read out the definition, but as you will see, it specifically refers to emotionally or physically abusive behavior, and there's no mention of sexual harassment in that definition. The American Medical Association goes on to say that bullying manifests from a real perceived power imbalance and is often, but not always, intended to control, undermine, threaten, or otherwise harm the individual who is being bullied. Now, the definition of bullying and harassment, I think, has plagued our field and has plagued the field generally. There are some kind of nuanced differences between what constitutes bullying versus what constitutes harassment versus what specifically constitutes sexual harassment. When we think about bullying, we think about a range of inappropriate behaviors that have a specific impact on the health and safety of the person who is being bullied. Now, it's important to remember that, there is a wide range of behavior that constitutes bullying and harassment. And these behaviors most commonly occur in the context of recurring interpersonal interactions. And that is so true, in the medical environment. So at the core, it includes any degrading or offensive behavior that undermines the self-esteem and confidence of the recipient, so the individual who's being bullied. Now, bullying can take many forms, and it can constitute a threat to professional status. It can result in isolation. It can occur in the context of overwork, and that is often the case. In clinical environments, it can result in destabilization. It's an important point to remember that it is a range of behavior that is highly gendered, that while males and females both experience bullying, and they may experience different types of bullying, females have been consistently shown to be at higher risk of bullying. And that's not just sexual harassment, it's other forms of bullying and discrimination. Now, perpetrators may be motivated by a desire to improve performance, and that's often the excuse or the argument that is put forward. It's a consultant or it's a registrar trying to get the best out of a junior doctor or student. But the intention is always irrelevant, and that's really important to bear in mind. And then numerous studies that have shown that, medical specialists, registrars, medical students, nurses, all define abuse differently. And as I said, that's been one of the problems that has plagued this field. It's, inconsistency in how we define bullying and harassment. And, different health professionals may define bullying differently and experience it differently. And there's also additional variability depending on the medical specialty that one works in, one's gender, as I've said, as well as ethnicity. So in medicine, mistreatment has historically stemmed from this teacher-learner power differential that is inherent in the hierarchy of medical education. And that has, over many, many decades, led to a cycle of abuse, what we can now kind of refer to as a transgenerational legacy of bullying, intimidation, mistreatment. And this is a transgenerational legacy whereby medical students who are mistreated often go on, as they become doctors, to mistreat other medical students. And this is a culture that has become part of the hidden curriculum in medical education. So medical education, is one of a kind of dominant teaching culture that is confrontational. It's often in the context of trying to challenge the knowledge and the learning capabilities and competencies of medical students and registrars. Now, this hidden curriculum has really had a very negative impact on interpersonal communication with colleagues, with peers in the kind of medical fraternity. And ultimately, it has a negative impact on patient care. So there are many different levels of factors that give rise to bullying, and we can think about them as, individual factors, or organizational factors, and health system factors. The individual factors, as I've mentioned, gender is an important factor because females have much higher risk. Stress, individual levels of stress, a perceived lack of autonomy, having role conflict or ambiguity in the medical workspace. There are also important individual level factors. Then in terms of organizational factors, obviously bullying culture perpetuates bullying and also facilitates bullying from continuing. in that space. Then where, consultants, medical managers have poor management skills, and are not really able to manage their staff in a way that kind of encourages competency, that facilitates respect and appreciation. Medicine, as we know, is a highly competitive work environment. Often you're working, if you're not working sort of in a tertiary academic setting and you're working in, community setting, there may be a lack of co-worker support. And then the health system factors, poor staffing, excessive workloads, and the power imbalance that, is inherent within medicine. Now, there are certain specialties that are at higher risk, and consistently emergency medicine, ONG, and the surgical disciplines are those disciplines where doctors and medical students rotating those disciplines tend to be at a much higher risk of experiencing bullying and victimization. These are also specialties that, are associated with long work hours, sleep deprivation, and then other specialties that are associated with poor less clinical supervision are also environments in which bullying tends to be perpetuated. So, I mean, how common is the problem? Is it as, pervasive as we say it is? Is this maybe an exaggeration? Is it a problem that maybe has got better over time? Well, unfortunately not. And, there's good evidence to show that rates of bullying and victimization have not declined over time. So in fact, the issue of bullying in the kind of medical space in academic medicine first came to light 40 years ago. It was a pediatrician, and his name was Dr. Henry Silver. He actually documented the rampant problem of bullying in medical students at his medical campus. And he reported this in a study that he published in JAMA. And what he said in his paper was that 46% of students at that medical school had at some point experienced harassment. But by the time they were seniors, so by the time they were sort of approaching their final year of medicine, that had increased to 80%. So it had approximately doubled. And he actually wrote that students went from being alert, enthusiastic, and excited to cynical, dejected, frightened, or depressed, and filled with frustration over the course of their training. And I think we continue to see that to this day. It's often missed. I think we often turn a blind eye. I think many of us who are in more senior positions may also, to some extent be in denial of the extent of the problem. So as I've said, there have been many studies around the globe documenting bullying and harassment in both medical students as well as doctors, and that's doctors across the board, although the focus has been on residents or registrars. And as Dr. Nyati pointed out, there have been only a couple of studies conducted in our country. So what do these studies say? Well, as I mentioned a few times now, the prevalence does depend on how bullying and harassment has been defined. But in medical students, the rates reported range from 10% to 98% of medical students sampled. And the rates also vary depending on the kind of geographical region. Now, in a study that we conducted in 2018 among medical students at one campus, the rate of bullying reported in that survey was 78%. So 78% of students between sort of their second and sixth year reported bullying. What about registrars? Well, studies have shown, and this is studies, that have been conducted across medical disciplines. There has been one meta-analysis of 51 studies that showed that approximately 60% of registrars are exposed to harassment or bullying. And verbal harassment is the most common form of abuse. Consultants are the most frequent perpetrators, and female trainees, once again, and those of ethnic minorities were at highest risk. So the study that I mentioned that we conducted at one medical campus was in a sample of 440 students. And once again, verbal abuse being kind of gesticulated at in an inappropriate way, being ignored or intentionally excluded by consultants or registrars were kind of reported as the most kind of common mistreatment experiences by students. As is the situation at most medical schools, the sample was predominantly female, so more than 2/3 of the sample were female, but you will see that, based on the year of study, there was a spread between the second and sixth years of study. I think what was most worrying about the data was that 1 in 4 medical students who were assessed on screening, so we included some mental health screening assessments, 1 in 4 medical students were assessed on screening to have a probable mood or anxiety disorder. And when students were asked whether they felt that mistreatment had contributed to their mood or anxiety problems, 3/4 of those students who were assessed as having a probable mood or anxiety disorder actually said that mistreatment had, in their minds, directly contributed to their problems. We also asked students to kind of provide more qualitative feedback on their experiences. I've listed some of those comments up here. I just want to lift up some of the themes that emerged. Students said that they were picked out for kind of being too sensitive, or they were threatened with failure of their clinical rotations. They were laughed at if they were not able to answer questions. There was also blatant discrimination, reports of white students being favored in theatre and males receiving preferential treatment over females. And a particular comment from a senior doctor actually highlights the sexist attitudes that are so pervasive, where a consultant said to this female student, "Why are there so many women in the operating room? You would swear it's a nursing school," to which the other doctors also laughed. So I've alluded to the consequences of bullying and the impact, but the consequences are far-reaching. They go beyond the individual. Aside from the mental health problems of depression, anxiety, alcohol abuse, burnout, deterioration in personal and family relationships, suicidality, which is often reported amongst both medical students as well as registrars. Individuals can also experience, a wide range of physical health problems on account of chronic or continuous bullying and mistreatment. But as I said, the effects extend beyond the victim to patients, to the team, to the organization, to the family of the person concerned. It also creates a poor learning environment. It erodes confidence. It leads to doubt. It instills doubt. It leads to dropout from medicine, reduced quality of patient care, absenteeism, and decreased staff morale, not only for the individual concerned, but also for others within the team. So I want to end off by just raising a few thoughts about what should be done to stop this. This is by no means exhaustive, but I hope that this will set the stage for the discussion that ensues. So because bullying in the workplace occurs as a result of individual, organizational, and systemic factors, prevention and mitigation strategies have to be implemented at all of those levels. And I think the hardest strategy to implement is that of cultural shift, is arguably that of cultural shift, because I think for so long, the hierarchical and kind of dominating and competitive nature of medicine has become sort of so entrenched. But I think the first step is, to clearly define what it is. So institutional policies have to spell out what they consider bullying harassment, intimidation to be. They have to spell it out. They have to provide very concrete examples so that staff and students and everyone working at that institution is crystal clear about what is not acceptable, what is kind of prohibited, what constitutes these bad, reprehensible behaviors. Also important to define very clearly for everyone concerned what are prohibited behaviors. And this really needs to be done at the start of medical training. It actually needs to precede entrance to university, but we see students entering into first year, and it has to be done at that point in time. Obviously, it needs to be called out when it occurs, as soon as it occurs. There needs to be kind of clear policies and processes in place for reporting and dealing with bullying, as well as immediate intervention, because I think that's what staff and students want to see. I think that is what kind of breeds anxiety when there is a sense of sort of, disempowerment, a sense that the institution or seniors are not responding promptly and adequately. So immediate intervention, but that has to be coupled with enforcement of consequences for perpetrators. And then, as I said, the most difficult, but perhaps, even the most tangible way in which we can approach this, and this is, I think, really important in terms of prevention, is to make sure that, we are working with an environment that fosters respect and appreciation of colleagues at all levels, that the environment is safe, that students and staff are made to feel safe, and that they're also safe spaces, and these can be created, safe spaces in which such experiences can be discussed. This can be done in peer groups, it can be done with both supervisors and more junior colleagues. So I want to end off with this quotation by President Theodore Roosevelt, who said, knowing what's right doesn't mean much unless you do what's right. Thank you very much for your attention.
Thank you so much, Prof. That was very much enlightening. And I think, a lot of comments have been coming through the whole time. And I'm just going to read an email that came through us, and like someone that's almost lost for words, and then we'll just continue going to the other questions. This one was just like sent a specific email to us. It was just a very short description. I feel like I was bullied. I reported it. I even went to head office, and I was promised that the person that was bullying me, perpetrator, would go to anger management. This was in 2014. I have not had any feedback. And now the bullying and victimization and abuse has multiplied. Where do I go for help? I am afraid that the bully has more power, connections, and a nobody like myself is only asking for death if I continue to pursue this case. Meanwhile, bullies are shaking in their long stilettos and worshipped by everybody. Where do I even start? I mean, the person goes on to even say it has affected my family, how she's depressed and her whole family is deteriorating. I'm even regretting why I'm working in this place. At the same time, where do I go to get a new job at my old age? So I think this is just a reflection on how people on the ground are really having difficulty. And as said, that this is a topic that has been put off for too long. And we hope that this is not the last episode, as definitely we said with Dr. Nyati. So just something that I would like us to go to, Prof. Lova. I'm not sure, Prof, your laptop, is it sustaining you to be able to just talk to us for even if it's just like 5 minutes?
Yes.
Thank you so much. So Prof. Lova, for those that have joined us, is the Dean of UKZN, the Health Sciences faculty, and she's also a specialist dermatologist. Thank you so much, Prof. You can see it on her skin that she's a dermatologist. That's how pure her skin is.
Thanks, Dr. Miller. I'm going to switch off my video because I'm trying to preserve load shedding here. I think load shedding is bullying me today in line with the topic tonight. So I don't know, Dr. Nyati, I'm so happy you have raised this topic. And in fact, we were in the same class with Dr. Nyati, and it's still interesting that we thought about the same topic around the same time, because I am literally planning a similar topic at the UKZN. We will let you know about that. We have a number of speakers there, but this is such a great appetizer for this very important topic that affects our clinicians and our doctors. If I may, again, I know I'm really working in the dark here. I want to quote B. Kudney, who says, hurting someone's feelings is as easy as throwing a rock into the ocean, but you never know with how deep that rock will go. I thought that resonated with this topic so much. And again, the fact that, no one has ever made himself great by showing how small someone else is. And this is what Professor Suraya has really been talking to in an amazing sharing the talk, quoting all those amazing clinical research that has been published in the past. So, Dr. Nyati, I'm not sure, do you want me to, the first question that you asked me was whether I have experienced academic bullying. So the response to that question is that on a personal note, I haven't experienced academic bullying. And as you have heard from Professor Suraya, there's a prototype of victims that can be bullied. They fit a certain prototype, a certain type of people. And I think maybe I was fortunate that I fall outside that prototype of being a victim of being bullied. I have been a victim of racism and sexual harassment as a medical student, but not academic bullying. So in terms of our institution, I don't know, Dr. Nyati, do you want maybe to ask those questions, or must I just go through them?
I think, Prof, the questions were just a pointer to help us understand, especially as a dean of a faculty, just those questions. You can just go through them and just highlight them, because I'm just worried about time that we might run into. Thank you.
Okay, thanks, Dr. Miller. So one of the questions that Dr. Nyati has raised with me was whether UKZN has formal policies and reporting procedures for victims of academic bullying. Yes, UKZN does have the rich values. We also do have a disciplinary code and grievance procedure for staff, and cases are reported to HR. In my experience, it's always been a problem that the victims of academic bullying do not report. That is a real challenge. They do not report the issues. There's a recent incident that has happened. I think as a dean, I have been involved in 3 cases of academic bullying. And I must say, on a personal note, this is something that I will not tolerate from anybody else. And I'm there as a dean to look after the interests of the students, the registrars, the consultants, and everybody. So what is important is very crucial for our young colleagues, junior colleagues, and even consultants for that matter to report it, because when it comes to HR, they need evidence. There's nothing that they can do without proper evidence and recording. But what I must say, I am so grateful for some of the young doctors with whom I've been involved in some cases of academic bullying. In UKZN specifically, there was an incident where a doctor of a particular surgical discipline was actually dismissed from the institution because of academic bullying. There was one case like that. We've also had cases when one other head of department, I was involved in that case and I had dealt with that. He was also requested to resign. And there are a few who have gone to an employment assessment program where they've been assisted to deal with their innate issues that make them academic bullies. So we are taking great and grave measures to make sure that this does not happen. But I want to encourage all the young colleagues, people, please, we rely on you. I was so sad with the recent incident to hear that it's been happening for 10 years. Nobody had reported it until one brave hero stood up and said, enough is enough. And that's how we could deal with the culprit. You've got your cell phones now, record them. If they say, demeaning or they destroy your soul, record them and use that as evidence, because that's what we want to hear. We are not going to tolerate academic bullying. This is not the place. We have to create nurturing environments for our young doctors and clinicians. So I will just end there, Dr. Nyati and Dr. Miller, and I'll still remain here for any questions.
Okay, Prof, thank you so much. Just maybe a quick direct question, Prof. Do you think your battery would last you for the next hour and a half or so? Because there's some questions that are specifically, that if you're still on, I'm sorry guys, for those that joined later, Prof. Lova is experiencing load shedding, so we are being bullied by ESCOM. So I just want to say, if we can still hold on, then we may maybe just.
I'm looking at my battery, it's saying 1 hour, 36 minutes.
Okay, no, we're good. Okay, no, it's fine. Let's just get the other panelists to talk and then we'll speak about the specific questions later. Thank you so much, Prof. Now, I have the pleasure of introducing Umkhaya Wam. So for those who don't know, we come from the same small whole town. Dr. Flavia Senkubuke, she is the president of the College of Medicine of South Africa. And I think a lot of people, we're very fortunate, I think a lot of people are going to have questions directed for her, especially the registrars. Dr. Flavia, can you hear us?
I can hear you very well,
okay.
Dr. Miller.
Thank you so much. You can come through. Thank you.
Thank you very much, Dr. Miller. And it is true, Dr. Miller is Umkhaya Wam. And I firstly want to say thank you so much, Dr. Nyati, for this incredibly important conversation. And I hope that this is a first of many. I want to say, Dr. Nyati, that I was really flattered and very humbled by this invitation, particularly sharing it with such incredible speakers. And it's not lost on me as in my current position as the chair of Women in Global Health South Africa, that you have an all-women panel. And I must say, I want to acknowledge that because it is an important step forward as we tackle some of these difficult conversations. Mine is going to be a little bit different. I'm going to talk about my experience as the president of the Colleges of Medicine. I'm also going to talk as somebody who really leads a number of organizations globally and also nationally. And then I also want to end off with some of the practical steps. And in our conversation, I thought, Dr. Nyati and Dr. Miller, that the first thing that we really need to do, and I've sort of titled my talk, Beyond Institution to Self. And one of the things is about positioning oneself in the bullying conversation. And so asking yourself, how am I bullying? How am I healing? And how am I dismantling? I think these are three critical questions, because then you center yourself and you put the I bit of it. And a lot of times in our conversations, we look outward and we look at institutions, but really, first of all, it's an acknowledgement that the definition of bullying and the mechanisms of bullying have expanded so much. We now have new modalities, social media bullying, so it's no longer the play school or ground school bullying. We have bullying in terms of let's mobilize and ensure that we bully X and Y. We bully with use of our language and emails. We bully when we gossip, when monger. There is also, as Professor Sida talked about quite eloquently, and also Professor Adlova, around workplace bullying. And so I have written here in terms of really locating it in practicality when Professor Sida talks about our academic term of transgenerational bullying, but I've termed it and I've written it plainly and saying, we have become the bullies. And so in locating that, we need to understand, first of all, and acknowledge that these things are not far removed from our lived experiences and our lived reality. So it is important to locate ourselves. And again, I asked my first question. It is, how am I bullying? And the question of how am I bullying sometimes is really in simple things. How am I being unkind? How am I being not compassionate? How am I being not sympathetic and not empathetic? And the first thing, in terms of practical examples, I remember when I was elected, in all the organizations that I am elected in, and I also tell my mentees as well, the first thing that I always do is to conduct what I call listening tours. And the listening tours serve two purposes. One is to get a mandate from the population that indeed you can lead. The second thing is to understand that bullying in our sense, whether it's in Africa or globally, has got a historical context, especially in our medical fraternity. And Professor Seeded and both Professor Ngoza have talked about this hierarchical nature. We normalize that the best doctors are those who've gone through run-of-the-mill. I always tell my students that when I first got into medical school, I found it very strange that we have had, the construct of learning has got to be in the space of harshness and unkindness. And so in essence, we have to understand that we need to denormalize. The only way to study is through harsh environments. The best way to study actually is by being kind, compassionate, and empathetic. And during those listening tours it's actually to locate and understand the fact that our people have give people a voice, because they traditionally have never had a voice. And so it can take you a year sometimes. Say, for instance, like at the colleges of medicine, when we were elected, we went on the listening tours across the country, listened to the professors, listened to the students, and our role was really to listen. And once you open yourself up, and as I said, I want to give practical examples. It may not come out as these neat little packages of, good morning, Madam President. I really want to politely say, these are the things that are happening. It may come out in harsh tones, in things that may hurt you yourself as a leader. And you may think, oh, maybe I shouldn't have, put myself out there. But you must understand that it is not personal. It is because times this is the first platform, even for the teachers, the consultants, that they are getting their voice heard. That is 20 years, 30 years of pent up quietness and stillness where you can't say anything. So it may come out aggressive and know that that voice may not always be neat, but that's okay. But hear that voice anyway. And so it's in creating those open spaces for our students, for our lecturers as well, the consultants, because they too bully each other. We bully each other, the students bully us, we in turn bully. So it's a whole cycle. And so the first thing is in creating those spaces where we hear each other and listen to each other. Again, I talked about dismantling. And so it's a dismantling this notion that I can only learn from somebody who's superior to me. A lot of the work that we have done at the college, in fact, has been around and comes from the registrars themselves, where we have an open policy of, you can email me as Madam President and say, you know what, I do not like this, and I think this. For instance, if I can give an example, for instance, we have a feedback mechanism now at the college that came from the registrars during their listening tours, where they said, if something goes wrong, I need to know where I went wrong. And so for yourself as a leader, it's in that understanding that the voice of colleagues and the voice of your stakeholders is the critical voice. The second thing is that, and it sounds odd, you need, and the old adage of Ubuntu, I am because they are. And in recognizing that old adage, and it's actually very simple because it's our African nature, it's in us. And when you lead with heart and people see your heart, and it becomes easier to recognize that some of these spaces, it's about creating a softer landing for our students and just opening your heart, and also our colleagues as well. And so it's in creating those policies of saying, for instance, in the college, we have a term now that you say, well, this is the people's college. And so it's in locating the humanity. Things happen. What are our students, for instance, our registrars, divorce, when they have bereavement, when our colleagues can't anymore, they are stressed out. Your policies and the way you structure your program has got to give that leeway. When female registrars fall pregnant and they are off for 4 months, what are these policies that we've put in place where we say, indeed, Flavia, we recognize you not just as a student, but as a complete human being? I always say to my registrars, it is a very good thing for you to qualify with F, whatever it is, a fellowship. But the most important thing for me is to ensure that your grandmother still recognizes their child. And in that, it is about us ensuring that we have a whole specialist, not just as somebody who's a number or who's got these fellowship, but it is somebody who is whole, and understanding that, yes, we need to technically teach our candidates, but at the same time, we need to ensure that we nurture the whole human being. And then we have to call each other out. It's so important. So that I go back again, Dr. Miller, in saying, how am I? How am I standing up when a colleague is being bullied? How am I standing with? And so this issue of calling out becomes very important. And here I wrote support, support, support. How am I supporting others in terms of normalizing kindness? It's in these tiny little things. Sometimes it's not very big things. It's in these tiny little things. So as leaders, for instance, you're chairing a meeting, the first thing that I always say in meetings is that, thank you, welcome to this meeting, whatever it is. In this meeting and in this organization, we treat each other as human beings, and we speak with each other with kindness, with compassion, and with empathy. And you say it over and over. And so that then means that you need to bring your best self. And if a colleague goes out of line, which sometimes it happens, you need to call them out and say, Professor so-and-so, Dr. so-and-so, or student so-and-so, I've heard you. But in this organization, what we are trying to do is to learn a new language of kindness and compassion. And so I want to end off with a couple of pointers. The first one is, as much as we're talking about changing culture, we need to have tangible policies. So for instance, at the colleges of medicine, we've got a candidates policy, we've got even requirements of examiner policy, where we have these things which are not traditionally there, these salient things. You will speak with kindness, you're not allowed to be rude, you're not allowed to do this, you're not allowed to do that. And over and above that policy, you need to aggressively implement it. And so if you see that something is wrong, you need to call it out. And so even policies that you put in place around, how do you address, how do you structure an email, and call those kinds of things out. And there needs to be, I've seen, for instance, in the chats that if somebody goes and reports, nothing happens. You need to make sure that even if there is that policy, part of the change in culture is to ensure that the policy is implemented. The second thing is around inwardness. How am I bullying is a very important thing. And so that inwardness is very important because, as I say, which Professor Cedars had so beautifully said in her introduction, it's around the fact and recognizing your own pain, your own hurt, and how you are giving it to other people. And so, for instance, you will find people like Professor Cedar, people like Professor Ngoza, and many colleagues who are on the webinar are, as I call us, the first Black woman in, the first Black person in. How are you supporting those people? So when they do well, do you ever send an email to say, well done? For instance, just this morning, I got an email from a very senior colleague who said, Flavia, well done on the work that you are doing at the college. We recognize it, we see it. It just warms your heart. And I also get emails with colleagues who say, can we please have a coffee? I've got some ideas in terms of implementing at this organization and that organization. Inwardness is something very important. So how are you supporting other colleagues? How am I, as Flavia, supporting Professor Ngoza to say, you know what, my sister, and I say to Professor Cedars, my sister, I know what you're going through and everything. Let me also have a coffee, just a Zoom coffee, to check on you and see how you are doing. we have to recognize our interconnectedness. I am nothing without my registrars. I'm nothing without the consultants. I'm nothing without the humanity and all the collectiveness of the people who made me who I am. And so that humanity is so critically important. We need to see our registers as whole human beings. We need to see them, and a lot of this, and you can say it in your speeches and everywhere. So for instance, one of when we came in the college, one of the first speeches that I made was it was around building a new architecture for the college. And in that, it was really recognizing that our registrars are mothers, they are fathers, they are daughters. They are not just a registrar. They are somebody's daughter, somebody's child. Our consultant is somebody's husband, somebody's daughter, somebody's father. That just spins your language in terms of how you recognize a person. And then we need to examine the way we bully. Is it in kindness? Is it in tones? What are some of these things? Even just saying to somebody, oh my goodness, I like your hair, I like the way you are dressing and that type of thing. I want to give you, for instance, it's things which are small. So for instance, in our department, we travel a lot in my department at the university. And everywhere you go, whether you're in Spain or UK or just Eastern Cape, you bring your colleagues a present. So I've got presents from countries that I've never been to. And it's in just those tiny little things that say that when I go home to the Eastern Cape, I bring a small little bead from my tiny little area, and then colleagues always remember that I am loved, I am thought about. And then we need to support and resolve that not in my name. And so these are kind of the parameters that I am drawing. And last week I attended, and I want to end off by saying, last week I attended a conference, and one of the speakers ended off with something that I thought was so important, Dr. Miller, for this particular conversation. And she said, we need to build trees under whose shade we are not going to rest. And that is the key thing. Our registrars, our consultant, and the kindness, it is not a transactional thing. It is building that tree and making sure that the people who have been entrusted to be in my world, to be in my vicinity, leave better than when they came. Thank you so much.
Sure. Yeah, thank you so much, Dr. Sinkubuke, Dr. Flavia. I think, you know, the topic is very heavy, and it's very good that we also check inwardly, because it's very easy to blame. It's very easy to point fingers. But, you know, as a ComServe, when you were telling that intern to go do bloods, you know, just the manner and the tone of, you know, I'm just like, yeah, I also did this, like also this was done to me. It's those small things, but thank you so much for pointing that out. And, you know, what are we taking from your, from what you've said is that the biggest thing is Ubuntu. You know, it's very interesting that if you'd ask most of the people why they did medicine or they're in the health space, is to take care of people and make people feel better. But somehow we tend not to take care of ourselves and take care of our colleagues. So thank you so much, Dr. Flavia. There are some questions for you. We'll speak about them just a bit later on. I'd like to also just introduce right now Liesl Anthony. Liesl Anthony is a clinical psychologist who is currently passionate about employee health and wellness, and she's currently doing her PhD at the University of Walter Sisulu. Oh, sorry, University of the Western Cape. Apologies for that. Liesl, can you hear me?
Yes, Dr. Miller, I can.
Thank you so much.
Thank you so much for the introduction, and thank you for asking me to speak. Two very eloquent speakers that were just before me, and I think, like you said, this is a heavy topic, and we probably won't get to the bottom of it all. Mine is especially heavy because you've asked me to speak a little bit about the perpetrator. Who is he or she, and what are the characteristics around that? So I'll try to be as brief as possible, because I think Prof. Sidat touched on a lot of what I've also wanted to talk about in terms of consequences and impact. So I think there's been a wealth of information internationally, and now also coming out of South Africa in terms of bullying and the impact of bullying. But I think not a lot has been said in terms of understanding the perpetrator, or really what motivates the perpetrator. I think, like Prof. Sidat also said, the intent is not really what we want to look at, but I think one needs to understand where it's coming from. So in my very brief discussion, I will be factually locating it in terms of what available research currently is saying us about the psychology of bullying and the different type of characteristics. But before that, just briefly, I think medical training usually takes place in institutions that both speakers have spoke about. It's a highly structured hierarchical system. And research has shown us that the teaching practices has involved, some level of intimidation and humiliation. And these systems and traditional practices foster normally a culture of bullying and the setting up of a cycle of bullying. Similar to other cycles of abuse, it's very similar, and in which some of those who are experiencing the bullying actually go on to become bullies themselves when they are in more senior positions. So medical doctors and students now are increasingly reporting being bullied, often by older and more senior colleagues, and many of those have been bullied themselves as juniors. So we really need to look at the individual, meaning the perpetrator, and the hierarchical system, as well as the institutional culture, when we want to really address the issues of bullying. But let's take a brief look at the perpetrator and what the research has highlighted. In a 2016 literature review on bullying in a hospital setting, it was found that there are particular characteristics that identifies both the perpetrator, the victim, and the organization. But in terms of the perpetrator, what it has highlighted is that the perpetrator are normally experts in their respective field. The workplace with the ability to decide.
Oh, okay. So I thought we lost you there. We could not hear you. Sorry. Well, yeah, you can go back. Sorry.
Okay. Okay, so the perpetrator are normally all experts in their respective fields. That's one characteristic that stands out. And they are very powerful figures in the areas of expertise. And they have the ability to decide whether they share information and knowledge and resources with others. So that is one characteristic that stood out from the research. And that they had very strong personalities, or they were perceived to have very strong personalities. They were also seen as having negative working relationships with their co-workers. So they were regarded as people who show professional jealousy. There's some insecurity and even hate towards other co-workers. There's normally power struggles between the victims and the perpetrators. And perpetrators are also seen as withholding information. And they were all there's persistent criticism from perpetrators. They constantly remind the victim of errors, and there's excessive monitoring or micromanagement of those junior to them. And sometimes juniors are being ordered to do work that the bully is normally older, physically dominant, a superior at work, and exudes an effective posture of intimidation. And whether this bullying is real or imagined, the bully has the illusion of power over the victim. So a lot of different characteristics. I'm sure people can probably, identify with some of that in terms of people that they might have had as perpetrators in the workplace. Furthermore, research has also found that perpetrators lack personal awareness. So they might not be aware that they are seen as a perpetrator. It appears that they are completely unaware of how they are being perceived, and they often find ways to justify their behavior. Like Professor Sidat also alluded, it's seen as, I'm just pushing this person to do better, or to actually achieve more in this field. And they have no concept of how their peers actually perceive them. And they consider themselves as well-liked, but this is really based on fear-based manipulation, and people are being too afraid to speak up. So we have in the cycle of abuse your silent bystanders who stands by, they notice the abuse, but they don't really speak up and they don't say anything. And this can actually cause the perpetrator to think that what they are doing is correct, and that they are justified in their behavior. Some of these perpetrators actually have very low self-esteem, although they are experts in their different fields. They often see threats everywhere, and threats of inadequacy. They see others might be a threat to their status, a threat to their position. And they lash out as a defense mechanism, and they often seek out weaker victims in order to bolster their own sense of superiority. They have a need to feel in charge of someone. And here a little bit just about some of these perpetrators. Some of them might have had a little bit of disorganized or dysfunctional upbringing with a lot of big changes where they felt completely out of control, and they might lash out and assert their dominance as a way of asserting their control or as a means of coping. So major changes in the workplace or volatile circumstances can make a bully feel very vulnerable. And if they have the ability to be aggressive, you will then see that they start to turn to others to victimize them in order to feel in control or to protect themselves in that situation. And that helps them to cope and have a sense of normalcy or control. Bullying has also been associated with antisocial personality characteristics, with narcissistic personality characteristics, and with a Machiavellian characteristic. So just to briefly, a person with narcissistic tendencies will have an extraordinarily high opinion of themselves and require others to have that opinion. They are dependent on the perceived adoration of others. And that's where bullying and narcissism go hand in hand. If a narcissist does not feel special, he or she will create opportunities to stand out or to feel powerful. They will then embarrass or harass or put others down in order to build him or herself up. Because in terms of a Machiavellian personality, this is a manipulative behavior that is motivated by personal gain. The individual is highly effective when reading others and anticipating responses from others in social situations. So they're able to quickly know what the response would be and able to counter a response, often in a very sarcastic or negative way, where the person would feel let down or the person would feel victimized or inadequate in that situation. So a person with Machiavellian characteristics is unscrupulously conniving and devout of any guilt when it comes to taking what they want. And this individual will use aggressive means if they believe their self-perceived supremacy has been challenged. And that is what a lot of bullies feel, that their supremacy has been challenged. In terms of antisocial personality characteristics, some characteristics of this individual include being insensitive, inconsiderate, reckless, calculating, and controlling. They're also very exploitive. They're unsympathetic and has a greater likelihood of participating in unlawful actions, and of which, bullying is an unlawful action in the workplace. Compassion and inability to empathize. So their lack of compassion and inability to empathize contribute to psychopathic ability and to mistreat others in the workplace. So there's growing evidence that bullies are often driven by professional jealousy and envy, as well as this feeling of inadequacy. And they might even pick on the highest performing or the most skilled students, where the simple presence of that student is enough to make them feel insecure. And that's when bullying can actually start. This perceived threat of they might expose my inadequacy means that they then start to ruthlessly start to control in order to overcome this feeling of insecurity, this feeling of inadequacy. So how does that happen? There's psychological defense mechanisms that they normally use, which could be conscious or on an unconscious level, such as transference and projection. And projection is a defense mechanism in which the person defends against negative emotions that he or she might be feeling by actually projecting or transferring those emotions onto the victim and attributing those to the victim. So a bully's sense of inadequacy is projected or transferred to the student or to the junior doctor through making them feel inadequate and insubordinate. And then that releases their own sense of feeling insecure. Another way that can happen is through displacement. And displacement is really the tendency of many medical educators to bully students, may operate on an unconscious level. And it entails the redirection of an impulse, normally aggression, onto a powerless target or victim. So how to explain that is that a senior doctor or professor could be feeling a bit of stress in a situation, in the work or in the family situation. They feel that they could not actually bring out the aggression towards either patients or family members. So what they do is to become aggressive towards junior or trainees doctors in the workplace. What sometimes then happen is that the victim can also then displace that feeling that they cannot subject to the perpetrator, started to actually have those feelings towards peers or even patients in the workplace. So it's a very destructive way of dealing with the feelings in the workplace that can actually have a threat to patient safety as well. And it can lead to, it inhibits colleague relationships and it impacts on teamwork at the end of the day. So in terms of the psychology of the perpetrator, there's a lot that can be said in terms of how they operate and what defense mechanisms they use. Just briefly, chronic bullying is associated with negative health outcomes, and we know that this bullying is chronic. It's not once off. It's not a single isolated incident. And that there are various things that Dr. Sira has touched on in terms of how people are impacted in terms of that. Just before I conclude, just to talk a little bit about what are the barriers of reporting bullying. And in a 2020 study, they've actually concluded that there are various barriers. People experience bullying in the workplace, but they do not necessarily, report this bullying. And some of the reasons are insufficient assurance of confidentiality, as well as a lack of clarity regarding whether the incident falls under the jurisdiction of the university or the jurisdiction of the hospital. And that is a reflection on the fact that grievance policies are then unclear. Grievance policies do not normally this type of bullying. They also felt that outcomes were characteristics as inadequate. They perceived there was also a fear of victimization. They perceived a lack of anonymity, prevented dependency on senior doctors to sign off. So logbooks needs to be signed off, and that's why people will definitely not report. They want to progress, and they feel that they will be victimized, and that will impact on future employment as well. They felt that another barrier was that senior doctors are, they are connected, they have networks, and that will prevent them from getting employment. So in order to conclude, bullying is a complex type of unprofessional conduct in the workplace, and it has severe psychological consequences for the victim. And it happens as a combination of individual, organizational, and systemic issues. And all of that needs to be addressed to really address the issue of bullying. Thanks.
Sure. Wow, Lisa. Yeah, I think everybody, at home is just like, wow. Thank you so much for unpacking that. And especially, because you are the one that's victimized, I had my own experiences playing in my head as you were saying everything on how, being a strong personality, you just, in ward rounds, you picked it, and you just made sure you always know your work so that you're on top of your game and never questioned or maybe, put in a very uncomfortable position. But yeah, thank you so much for that. I think there's going to be lots of questions that are going to come up, but I think the biggest thing that's coming out is that, understanding that these people are sick in a way, they've got mental problems that they might not be confronting and even know about. And how do we as healthcare professionals that are advocating for everybody's health, also advocate for their health. It's a tough one because you're like, I'm the victim, but yeah. But anyway, we'll look into that. Thank you so much, Lisa. Up next, we've got Dr. Nomthandazo Dube, who's a neurosurgeon, and she's just going to be speaking a bit about her experiences. Dr. Nomthandazo, yeah, sorry, I think we're going to run out of time. So yeah, you can just please take the platform. Thank you.
Good evening.
Good
I
evening.
hope you can hear me.
Yes, we can hear you loud and clear. Thank you.
Thank you so much for inviting me to speak. And good evening to everyone, all the participants, and to the panelists. Wow, I'm actually having flashbacks as everybody's speaking, because everything that everybody has spoken about, some of them I hadn't processed or I hadn't thought about, and now they're starting to make sense, So the reason I was invited is that was to share my personal experience with bullying as a neurosurgical registrar. And what I remember is arriving in the department on the first day and my consultant saying to me that, what are you doing here? You don't belong in neurosurgery. Neurosurgery is for men, and you need to find another specialty. And this is my first encounter in the department. And, that I can't describe the feeling where you're confused about, what did I do wrong? Already, I don't belong here. So the next 5 years is going to be very difficult. And, I think it was Dr. Flavia that was talking about standing up for colleagues. And it's something that I'm just thinking of now, that in the first month or two, there was another registrar, a female registrar in the Department of Neurosurgery. And I remember this specific consultant picking on her, and me standing and watching and wondering, why she was being picked on. He went to the extent of going and finding her a post in another department and coming back and saying to her, you need to leave neurosurgery, and I've gotten you a post in another department. And I was thinking, okay, I don't understand what's going on. Did she request the post, or, did he, and I later found out that he had taken it upon himself to go and look for a post for her because she doesn't belong in neurosurgery. Eventually, she left registrarship, and I continued alone in the department. But in my department, it was just this one specific consultant. Everybody else was, respectful. They treated me as an equal. But this particular consultant would point out only my mistakes. If I make a mistake, he would call me and say, come and stand here, come and see the nonsense that you've done. This is why we don't want women in neurosurgery. This is why women shouldn't be surgeons. And he would constantly belittle me. If we are having a ward round, I would be front and center. He would tell me how little I know, how I will never pass the exams, how I don't belong in the department. And this went on, for until he left the department, basically. But I found it very strange, that he was picking on me and not everyone else in the department. And I can't describe to you how demoralizing it is for someone to constantly be pointing out everything about you. Somebody constantly telling you how little you know, constantly telling you how you're not going to pass, how you don't belong, how you'll never be a surgeon, how you're not man enough to be a surgeon. And, I had to fight, everything within me to be able to continue with registrarship. I felt like I had to work twice as hard as everybody else to prove that I could become a surgeon. And I know one of the questions was, why do victims don't report bullying in the workplace? And for me, I actually didn't know where to go. I actually didn't know that I could report this individual. And, I wish that there had been a platform like this at the time, because then I would have been informed and I would have known what to do at the time. And I remember my prof asking me, when I eventually told him right at the end of my specializing, and he said to me, but why didn't you tell me that this was going on? And I said, Prof, I didn't know. I didn't know that I was being bullied for one. But number two, I didn't know who to go to and how to report it, because as a student and as a registrar, looking around, we see it happening in other departments. We've been seeing it all along in medical school, and you think that that's the culture. You think that's how we're supposed to be trained. And therefore you don't know how to report it, you don't know where to report it or who to report it to. And I think the other thing as well, being a woman in a surgical discipline, you also don't want to appear weak, because one of the things that happened when I arrived is I would hear things like, you're not good enough, you don't have what it takes to be a neurosurgeon, you're going to be telling us that you're on your period, you're going to be telling us that you have period pains, you don't have what it takes. So as a woman, won't be able to cope in neurosurgery. The work will be too much for you. And so then you then decide that, you know what, I'm going to show them that I can do it. So you now try to work twice as hard as everybody else to be able to prove that, yes, I am going to cope. I am good enough to be here. And I guess I'm lucky in that my prof always says to us that he was trained under very strict, very, I don't know how to put it, but he was also trained in that hostile environment. And he says that when he was trained, he said to himself that when I train other people, I will not train them the way I was trained. I refuse to be that person. And that, I received that, and I decided the same thing, that as much as I'm going through all of this, when I'm on the other side, I am not going to become the perpetrator. I will remember what happened when I was a registrar, and I'm going to treat my registrars the way I wanted to be treated when I was a registrar, because I remember what happened. So I think this is such an important topic, and I hope that we all internalize it. And one of the things also that I for myself, as everybody's speaking and as everybody is explaining the psychology of the bully, the things that we do as consultants, I'm looking within myself and I'm saying, what do I do that makes my registrars uncomfortable? Do I laugh at them, for example? Do I belittle them? Do I point out their weaknesses in front of others? And this for me is becoming the perfect platform, or for introspection, and also it's going to help me to change the way I interact with other specialists, with other departments, with our registrars, so that we have a better environment. Thank you.
Dr. Mila, you must unmute.
Okay, sorry. Sorry, I was just having difficulty there. Sorry, technology. Wow. Yeah. I bought a box of tissues today because these are not just stories. These are people's experiences. These are experiences that some people are still currently having. And we really hope that this platform and every other platform that will be established or will continue after this will literally help doctors, because we can't heal people if we are not okay ourselves. I think that's the biggest thing. And thank you so much, Dr. Dube, for showing them, there's nothing as good as standing in that podium and graduating like, yeah, Dilapa, I've made it, when everybody was saying you cannot. And I think, it speaks also to what Dr. Flavia spoke about, how do you go forward and make a difference, and how your professor was literally intentional about making it better in training than what he received. So we have Dr. Zolelwa Sifumba, who is a health activist and who has also suffered bullying, like, I mean, from medical school, the challenges she's had, and, you know, health challenges, or even just in an academic setting, and just also just nasty professors and, you know, people that are supposed to be helping you and teaching you. Dr. Sifumba, I'll give over to you, and then we'll deal with the questionnaire, just the results. I'll share my screen on what has gone on, and then we'll deal into the questions. I'm not sure, Dr. Nyati, if we do, lose time, can we go on ahead if the people are still interested? Maybe you can think about that for some time. Okay, you can go, Dr. Sifumba.
Okay, sorry, maybe we can shelve our questionnaire and allow people to ask questions or answer questions if we have time constraints. Otherwise, if people are willing to go on for another 15 minutes, we can do that.
Okay, thank you so much. Let's just give it to Dr. Sifumba and then we'll take it from there. Thank you so much.
Hello, everybody. My name is Dr. Zolelwa Sifumba. Everyone can hear me, right? Cool. So yes, as I said, Dr. Zolelwa Sifumba is my name. I am an occupational survivor of both multi-drug resistant tuberculosis as well as COVID-19. So both illnesses I contracted while on the front line. And I'm also a global health advocate. So I'm happy to be here as one of the junior doctors, because it's great to be here representing junior doctors, because we go through so much, you know, and nothing is done about it. So I'm happy to be here. Thank you very much, you know, for inviting me to be part of this conversation. And I really enjoyed, you know, the comments, you know, the speakers that spoke before, the panelists that spoke before. I really enjoyed what they were talking about, but I really felt as though the gap was, where are the junior doctors? You know, I had Prof. Jova speaking about, you know, in the university, and Dr. Flavia was also talking about in the College of Medicine. So I was, and that's with registrars. So I was asking myself, you know, where do the junior doctors fit in? And really, there isn't a place where junior doctors are able to voice out these things, where they're able to get recourse when they're bullied. So to start off, I was very emotional preparing for this talk. I think Dr. Dube said the same thing of things coming up that you hadn't processed, you know. So I realized that and Dr. Tlaleng on another webinar spoke about this, where she called it buried traumas, where things just keep happening to you and you just keep burying them. So I found myself in preparing for this, you know, someone was asking me, oh, how was this year? And I literally drew a blank for some of the years of med school. And I realized that it was because I was so hurt by the things that would happen, you know. And honestly, it's a cultural thing. It's part of the culture of medicine, and it seeps into everything. It's in the conversations that you have with people. So you never know if you're being bullied. And then when you are bullied, you'll be gaslit to believe that actually you weren't bullied, everything is fine, you know? So, and also it's very hard to talk about, because we are very hard on ourselves. We're very hard on each other as healthcare workers. So if you're talking about being bullied by someone, the usual response is going to be like, come on, you know, just, you know, take it and deal with it, you know? But I completed my ComServe last year, and I have completely run away from clinical medicine. And bullying is one of the reasons why I left. And I feel largely that I've been mistreated by the health system with my exposure to occupational illnesses. So I think this is part of a larger issue of the occupational health and wellness of healthcare workers, you know, in the workplace. So the bullying starts at medical school, and it's because you're all the way at the bottom of the pile, and everybody decides to treat you the way they decide to treat you, and it is what it is. You also are mistreated by other students because you're competitive. You know, people are out here trying to look good in front of the lecturer, whatever they're trying to do, but we end up mistreating each other and ourselves. But to think of, I've been sitting here trying to think of these things, and you know, they just keep coming back. So I just wanted to tell you guys about some of the things, you know, that used to happen to me at medical school, which were part of the culture. I mean, it wasn't something, so also you didn't report because you were like, yo, was that okay? Maybe it was fine. Actually, maybe I was just overreacting or whatever. So yeah, I was at the University of Cape Town, and I remember we had a very racist HOD. I think it was in the orthopedics department. Very racist, very sexist, all the time. And you must just keep quiet. Like, it's the weirdest thing where he'll say something that's very racist, and the blacks will look at each other like, wait, did he not just, and then he'll gaslight you, you know? But another thing that happened, you know, I remember when I was in medical school, there was one time, fourth year, I was post-core and we were doing a ward round, and I sat because I was tired. Next thing, I got a mouthful for about 10 minutes from the consultant telling me why it was disrespectful for me to sit down. She knew I was post-core. You know, she knew I was tired. She knew that I was, and it was like sitting, I was at the end of the ward round and I was just like, I really just need to sit. But anyway, I was shouted at. Another thing that's happened to me while I was a student delivering babies is, you know, you get ridiculed sometimes by the nurses for showing kindness to certain patients, you know. Another thing that happened is I saw, you know, on one of the ward rounds, you know, one of the really big professors, I saw her hit an intern on the head with a folder. And like, we all looked at each other like, what is going on? And like, everybody's just quiet, you know? And I told myself, okay, maybe when I get to that position, I wouldn't just keep quiet about it, you know? I wouldn't just, but then years later, I found myself in a situation where I was being bullied. Another problem, you know, it was spoken about that I think Dr. Flavia was saying that we should call each other out, but like, you call people out on abuse, you're gonna get into trouble. Like, and the person who's being abused could be fine. And then just because you decided, you know, you wanted to call out this consultant or this registrar, they're just like, okay, I'm gonna put you in your place. I was also, okay, so that was medical school. So it's just entrenched in you. And also you have these logbooks from medical school and you just have to smile and grin and tap dance and just be the girl if you want to get the signature sometimes, you know, and it's not even about the clinical acumen, you know. There was a situation where there were two students, me and another student, and the nurse didn't like that the student was being kind to the patient. So she marked me as excellent and then she marked my friend as poor. That time my friend was teaching me things. And I was just like, I don't understand what's going on. Anyway, over on into internship. So I was also the intern rep in internship. And I experienced a lot of things myself, but I would get stories from people. So I remember when I was in internship, one of the interns was forced to do a C-section on a dead body. One of the consultants were just like, hey, go do this. And when she came and told me about it afterwards, I was like, that's not within our requirements. Like, that's not a thing that interns should be forced to be doing all the way in mortuary by themselves. But she couldn't say no because she didn't know. She was afraid of the position that he held. He was whatever. We're afraid just for many reasons, you know. I've been in rooms where interns have been told to stop crying, like, and I'm just like, what do you mean, you know? And another thing that happened to me when I was an intern is a few times, but there was this one really big time where I was blamed for a patient's whole death. Like, as a junior doctor, as the intern, they were like, it's your fault, you know, this person died. And I was just like, but I don't, and that day I happened to be alone. There happened to be no senior. So I was just like, what did you expect me? How did you expect me to make this decision? First of all, without you. Second of all, now you're blaming me, you know? Anyway, yeah. And then the last thing I want to talk about, you know, my own experience of bullying. I think bullying even happens in times of a pandemic. So last year I was in ComServe and it by far was the worst year of my career. And I've had pretty tough years. I got multi-drug resistant TB as a medical student. Yeah, you know, lots of things have been happening to me, but last year was the worst year of my career and I actually had to leave. I always knew that the risks in clinical medicine in terms of getting sick were high, and I knew I wanted to leave eventually, but then I just got to ComServe and I was intimidated by my medical manager. So it all started, the only reason I was bullied was because I was trying to improve the situation. So what was happening was that at this particular district hospital, the rotations were really poor. You know, you're supposed to, as a ComServe, go and do 2-month rotations at the hospital so that you can find out, you know, what you're interested in and what you want to go into. At this hospital, we were not getting rotations. We were being very poorly supported by our seniors. And the biggest problem for me was the fact that in terms of COVID, we were not prepared, you know, and even though as COVID was coming in, we as the juniors were saying, look, we don't have this, what's going to happen now when this happens, you know? And we were being told that, you know, we'll see when we cross that bridge, you know? I didn't want to see when I crossed that bridge because I knew I'd had TB before, you know? So I was like, I am not trying to do that. So anyway, we complained and we complained and we complained and we complained. We asked for meetings with management. Eventually they gave us a meeting about like a month into the COVID pandemic, to which they weren't really listening to our complaints. And we were not complaining about small things. We were complaining about the lack of PPE. We were complaining about the lack of proper mechanisms, you know, to put, you know, we were seeing COVID patients in the normal casualty. And this like was an emergency for me as a whole, like global health advocate and a person who survived an infectious disease. It was like so important to me. But anyway, we kept complaining, but nothing was done, to the point where staff members started to die. I got infected, and my medical manager, in trying to deny that I got infected, you know, he, you know, first of all, traced some of my results without my consent, which was not right, and I knew that wasn't right. And the problem is, I tried to report it to people. I went to EAP. I was actually crying when I went to EAP. And then the following day when I arrived at work, I was told by EAP that I need to go ask him to sign off a leave form for me. And I was just like, but I was literally in your office crying about this man. And now you're just telling me to go back, you know? So even on the WhatsApp group, this man would like degrade us constantly, tell us we've got personality disorders, you know, tell us all sorts of crazy things on the group. Eventually I left the group. And yeah, as I said, failed recourse, you know, failed. I tried, I went to EAP, I went to, and it was being asked, why don't we complain? The problem is when we do complain, like first of all, who do we complain to? Second of all, you complain and then like nothing happens. And not even that nothing happens. The person you complained against finds out that you complained. Now it is hell. Already it was a hell, you know? But I am a whole seasoned activist advocate. You know, I've been doing this for years. I've been championing things for junior doctors, but I myself was put in a position and I still don't know what to do about it. You know, I got COVID and I didn't get any occupational benefits because this man denied completely that I was sick, you know? And then he went and forced me to get blood tests done. And then he checked out the results without my consent. Then he sent me a message afterwards to tell me that he sees nothing wrong with me. And he thinks that mental health intervention is what is needed. That time I had all the symptoms of COVID, you know? So you're gaslit. You are gaslit the whole time. And you think, okay, it's part of the culture, it's part of this. And even when you do realize you're being abused, it's like, what do I do? What do I say? Who do I go to? So I tried, you know, I'm here as the I tried girl. And I know many other junior doctors and many other healthcare workers who have tried, but just nothing happens. And in fact, you're treated worse for it. You're belittled, you're looked down on. Everything gets worse the moment you complain. So I don't even know how to tell people to complain because I'm just like, I don't know what's going to happen at your hospital. I don't know how they're going to treat you. I don't know if they're going to fire you. I don't know. And people are leaving the profession. People are becoming addicts. People are killing themselves, you know? So it really is something that needs to be done. We are voiceless, you know, and we need, and that's why I'm so grateful for this opportunity. And I'm hoping that this opens up, you know, for other people, doctors, to speak out against the things. And I don't even know, I'm saying speak out, but I'm just like, who do we tell? You know, like, and it's, so this is a really big frustration for me. But anyway, I'm closing off there. Thank you very much. Yeah.
Wow. Thank you so much. Thank you so much to our panelists for staying on. We've got about 20 minutes left. And I think, it's just important if we can go to the questions. So I will fire some of them, and I've just grouped them because most of them are speaking towards the same thing. So I think just the first one that came off, Prof. Lover, because we know that there's just some power challenges. The biggest thing that people are asking is that how do we report? You mentioned when you were talking that, it's academic, especially within the academic setting, because you are a dean at UKZN. How do people report? Many people find that there are no clear channels, be it either for student interns, for interns, or even for students, and also just the registrars. How do they report? And maybe I don't know if Prof, can you hear me?
Yes, I can hear you. I'm trying to wear my head light here.
Oh, wow. Thank you so much for braving against all odds to be here, despite ISCOM and all.
Yeah, I shall not be bullied by ESCOM. Thanks, guys. This has been really heartwarming, touching, inspirational, reflective, introspective type of discussion from all of you. And
sorry,
in fact, for me, my heroes again are those young doctors who have actually. Can you hear me?
Yes, we can hear you. I was just going to suggest maybe you can switch off your video so that, because I see your reception is not the greatest, then you can just speak. So maybe it'll come across a bit better.
Okay, sure. Thank you.
Thank you so much.
So I don't know how far you heard me, but I want to say that I am just, blown away, so touched and inspired by the boldness of you guys, these young doctors who are sharing their stories and decided to remain and continue with what you wanted to do. And again, my heroes, my real heroes are those students, whether you are a medical intern or junior doctor or a medical student, who will stand up and say, enough is enough. I'm going to take this to the powers that be. I do understand, even for the powers that be, many times I've experienced this, things will be shoved under the carpet and you will be told, please don't raise this. This person is going to be your examiner. Don't listen to that. Brave it. Persist, insist, and try and open all the doors until you get to the top. If your head of department doesn't listen to you, go to the most senior person. If the medical manager doesn't, go to the next senior person. Even if it comes to the deans or if it comes to the Minister of Health, go for it, because you are actually preventing your brothers and sisters from being subjected to this particular individual who's a perpetrator. So is so correct that, like he's saying, I don't know what to do, because you say report, but guys, remember, no one's gonna victimize you.
Okay. So I think we have lost Prof there as we We know like she was experiencing power issues, and I think also just the network was not the greatest. But I think the biggest thing, to take out from that conversation is that report in the structures. Yes, this conversation has alluded to many things that are not great in the institution in terms of reporting, but like, the chain of command that you have in a workplace, go through that chain of command. And yes, there have been people that have sent through their questions in terms of like, I've reported this, but nothing much is being done. But I hope that we will be able to come back with much more concrete solutions in engaging with the different stakeholders. Just questions that have come through for you, Dr. Flavia, in regards to the College of Medicine South Africa. So one has come through saying that they feel what is being done about registrars that have been failed deliberately and don't have much recourse in terms of asking for their transcripts and to see where they went wrong. One cited an example in 2018 in a specialty that they had. 11 doctors passed the speciality, and apparently the professor was not happy with one of them, and like about 4, their marks got recalled, and about 4 of them failed and had to re-register. But throughout that whole process, there was not great communication from the college side. And I think the many things that are coming out from the College of Medicine side is that people feel that there's no support for registrars, especially when you want to find out where did I go wrong and requiring feedback.
Thanks. I first, thank you very much, Dr. Miller. I first want to answer Dr. Zolela Sifumba when I was saying that you need to call colleagues out. I was meaning that as leaders, as people who are in leadership positions, we need to call each other out as consultants and say, you cannot treat your registrars like this, you cannot treat your students like this. And I think, as I always say, it's practical examples. We need to be the people who people like Dr. Zolela Sifumba can go to. And so in our little spaces, we need to make sure, she asked a very important question. Where do I go to? Let's normalize the fact that, we are the people where people can go to. Let's normalize vulnerability. We heard Dr. Dube saying, if you are crying, they'll say, you are not strong enough. It's coming from that whole culture of you must be stoic. It's the stoicness of our profession. And so we need to normalize that vulnerability is okay. And I always tell my students, even my undergraduates, if it doesn't feel right, it isn't right. If it feels uncomfortable, it is uncomfortable. If you have nobody else to talk to, come through and just say, you know what, this and this happened. What do you think? Is it wrong? And so you need to be the person who stands in the gap for your registrars and for your students. So to answer the question around the colleges of medicine, we have changed those policies. So I really want to encourage the registrars to go on our website and see these new policies, because we have had a massive overhaul and a massive reform. As I was saying, part of the listening to us was this thing around feedback. And now you don't even have to request for feedback. You get that particular feedback. So if you have failed, you go, you will, after that, you will get a full report of where you went wrong and that. And so these are things which we recommend. So there are a number of recommendations, but in the interest of time, we have had a number of recommendations that came from registrars, which we have implemented. I want to also add something else around communication and when we do have problems. I talked about the fact that we bully each other as well, that students bully lecturers, consultants bully other people. I mean, in terms of, so we will say, for instance, if I see Dr. Dube is not doing a good job, let me not mobilize each and every single person in order to ensure, and we say, Dr. Dube must fall, Let me go and sit down with Dr. Dube and say to her, my sister, you know what? I've had 1, 2, 3, 4, 5 complaints. And how do we work it out together? And instead of, I always say that when you come with a complaint, come with the solution. So let's also normalize, not mobilizing against each other, but making sure that we also support the people. If you heard Dr. Dube's story, it was so gut-wrenching that on top of all of that, myself now as Dr. Senkubuge, a fellow leader, will now mobilize against her. She's also, as I said, somebody's child, somebody's mother. She also bleeds, she also hurts, in as much as she is a leader. And so let's normalize supporting the leaders who are there. It is, for me, I don't want this to be lost, Dr. Miller, that when we leave, we only talk. That's why I was saying, let's look inward, that we leave here only talking about how our consultants have bullied us, or how, we also need to normalize how we are supporting each other in these journeys, because hurt people, it is true, hurt others. And we come from that history of hurt. And so let me normalize picking up a call to Dr. Dube instead of maybe, walking and making sure that I mobilize a whole mess of my own people to make sure that one of our top and only, probably one of only female Black neurosurgeons is hurt and doesn't even know. And as Dr. Sfumba says, leaves the profession, because we know that these things are happening. So let's normalize supporting each other, even as leaders and even as students. Let's normalize saying, I am not going to be a part of this. I would rather go and sit with Dr. Dube and find solutions.
Thank you so much, Dr. Flavia. And I think, that's very practical, that College of Medicine, the feedback mechanisms are there. Okay, so also someone is just asking contact details for the president of the College of Medicine of South Africa. I think that's readily available on your website if they would like to contact you from the site. Yes, okay. Prof has managed to join us via her phone. So Prof, I'll just let you to just finish off in that question that was posed to you. Thank you.
Thank you so much, Doc. The one more thing I wanted to say, I think Dr. Flavia just mentioned that as well, is that some of us in our own rights were also academic bullies. So when we leave this platform, we need to do some introspection, as Dr. Flavia mentioned. It's a hierarchical issue. The interns will bully the medical students. The final years will bully the fifth years and fourth years, and so on and so on. So the message that we also need to take, do some introspection. And this is one of my young mentors mentioned this to me, Dr. Mabaso, and said, you know what, when you're frustrated, you actually project your frustrations to the person who's junior or the person that you have power over. And that we need to be acutely conscious of. And also the leaders that need to take charge, and we need to protect our registrars, our students, our interns, and everybody. And I am making a promise that I'm going to take this up to the South African Committee of Medical Deans. And it's not longer going to be a topic that is shoved under the carpet. We're going to continue to engage. We're going to fight the scourge. We're going to eliminate these monsters that are thriving within our institutions. And we're going to do something about it. And I vow and promise to do that for everybody. Thank you.
Wow, thank you so much, Prof. I think it speaks to what Dr. Flavia spoke about. We've got very powerful people on the platform. I know earlier on people felt like it's an all-female platform, and guys, it just happened that we're all females, but it was never intentional for the men out there. But thank you so much, Prof, that we can hold you accountable to your words, and I know it's going to come into action. Just a couple of questions that have also come through. Someone says, my problem is that the elephant in the room is not in the room. We are suffering from predominantly white consultants in the institutions where racism is the baseline. That recourse is where the regards to all of this and institutionalized racism, I think it's more of a comment. And then I think this is a junior doctor, and maybe, Professor Sidat can help us with this one. Do you think that active mental health and personality assessments at the interview level of consultants or supervisors could help decrease the number of bullies hired? That's the first question. And then the second one is, I work at a secondary teaching hospital where we're forced to do exams and courses for you to show your seriousness in the specialization that you want. They then put you in a different department if you're taking too long to do that assessment or an exam. I think this is bullying. Am I right?
So thank you very much. To address the first question, personality assessments are a controversial selection procedure in recruitment processes. The personality assessments have to be correctly interpreted and applied. There isn't support in general when kind of recruiting registrars or doctors, for jobs in the health sector to administer personality assessments. I do think that we need to tighten up, and I can only speak, for my own department, and we have attempted to kind of tighten up our recruitment and selection criteria so that we can, better identify registrars, for training. I want to say that I don't think that personality assessments are the answer, because personality assessments are not necessarily going to identify bullies, as was sort of previously mentioned. There are certain personality traits and disorders, but they're quite widespread during medicine, throughout medicine. So, narcissism and, in fact, antisocial personality traits are quite widespread among highly successful individuals within the medical fraternity. The second question about sort of being shunted, that to me seems an unacceptable way of getting registrars out of a particular kind of training environment into another. I'm not sure how that happens, because there should be a formal recruitment and selection process. So I don't know how registrars are being transferred from one training department into another, but it seems to be an unacceptable practice. So I don't know whether it is kind of within, for example, surgery and between surgical disciplines, perhaps, within sort of divisions in a larger department. But I find it strange that that could happen, between departments or cross departments.
Thank you so much. Thank you so much, Prof. I think just another one that's coming through is that, can anyone on the panel advise whether there is a policy regarding, a head of departments? I think this is more in just how maybe they are appointed. The question was just not so clear. Okay, maybe let me just ask if Kosana can just elaborate on that question further. So I'm not sure if you can just do another 20 minutes with our panelists. Are you guys okay? I'd love to. So we had even 10 minutes. We had a survey that we conducted, and more than 250 people. It was anonymous, and we were looking back with Dr. Nyati, and actually, we wish we had gotten ethics approval, because this is very good information. But anyway, hopefully that will come. But if maybe Dr. Nyati can allow me to just share my screen. This will just, so what happened was in the survey, there were different questions asked. And as of now, the 261 responses that came through. Let me just see if, okay. Doesn't look like I can share it on my screen, but of the age group that's predominantly experienced, just in the demographics, more than 45% were mainly between the age group of 30 to 39, and 34% was largely between the age group of 20 to 29. So it's mainly people like youngish people, and as I said, it was 261 responders. 261 responders, sorry about that. And of that, the male gender, it was just actually, as with Professor Sedat, 28% were male, which equaled to about 73 of the participants, and the rest were female at 72%, and the race groups were very vast, Blacks being 57%, 17% being white and Indian, and Asian being 19%, and colored taking up the rest. The highest qualification that the people had that filled out the survey was in MBCHB, and of that, about 61% had MBCHB, and others were registrars. They were 17% of the population that filled out, and also your postgrad diplomas that they had. About 40 of them had postgrad diplomas. Current position held, most of the people that fill out the survey were medical officers, sitting at 39%, and registrars 16%, And consultants came through at about 15%, and 9% were head of departments and service administrators, and the rest were filled out with students. The current number that were in the public sector was 76%. So more of the people were in the public sector than anything else. And both in private and in public were about 8%, and then 15% just in private. And the question when asked about if you have experienced bullying, 96% said yes. I think for us that was the worrying number, because that came down to 251 of the 261 people experienced bullying. The others were not sure, or they said no. And the biggest amount of bullying came through undergraduate and internship. 170 experienced it during undergraduate, 176 experienced it during internship. So, it speaks to the lots of concerns that people have been having, that in your undergrad training, you are harassed. The natures of bullying, mainly it was verbal or victimization and malicious behavior and so forth. Physical, there were about 8 people, but what was worrying was that within the sexual bullying and sexual experience, about close to 30, about 27 experienced sexual. And this is worrying because it's literally, that's criminal behavior more than anything. And and about 81% of people felt like they suffered stress, burnout, or mental illness from this experience that they've had. And the biggest thing that we are finding in the research is that 176, which constitutes 68% of the victims, did self-management, about 62, which equates to 24%, sought professional help, and 58 just did nothing. Well, there are those ones that did raise grievances, which was at 67, about 26%. But majority of people are just like managing itself or just not reporting. And many people felt like that the chosen intervention that they chose, be it either self-management or raising up the grievance, many people said it really did not help, about 46%, about 42% of those. So that was just the numbers that came through. And just an interesting one, a final one, besides the open-ended questions, it was, do you believe bullying is a violation of human rights? And 97% said yes. So this is just, adding gravitas to the situation. And I think, I'm not sure if there's any question that, oh yes, the question was better explained with Post Kosana. So HOD's involvement in research projects, is it mandatory for a HOD to be a co-author or a co-supervisor in every research project conducted within the department? What recourse does one have if this is insisted? I think Prof. Lova and Prof. Sidat would help in that, because they've got, I think, lots of papers written under their names. Thank you.
Yeah, hi, hello, Dr. Emil. If I may respond to the last question about co-authorship. Actually, there are strict and clear guidelines about co-authorship and what one should contribute in order to be a co-author. We can share those with the colleagues here. It is not necessary. The only problem is that, again, you may feel a victim if you don't include your HOD, but you don't have to. They have to earn being a co-author. They must supervise you. They must contribute to the project, writing up the ideas, collecting data, whatever it is. It's not automatic that your HOD will become a co-author. I'm sure Professor Sidat will also add a few points to that.
Yes, I would argue that's unethical behavior. If an HOD is insisting on being a co-supervisor of every project, as well as being a co-author of every research project conducted in his department, that constitutes unethical behavior. As Professor Dlova has said, any individual, if it is the HOD, needs to meet the criteria for co-authorship, and that's spelt out by the International Committee of Journal Medical Editors. So there are very specific criteria that need to be met. So it is very concerning to me that, an HOD is insisting. And I think what recourse do you have? I think, this is something that should be reported to the dean. to the vice dean or dean at your faculty.
Muted. Thank you so much to our panelists. I think we have addressed lots of questions. It was mainly questions on the reporting, I feel. And I think one big thing that came out from this conversation is firstly defining it. You know, how do we define bullying? Because some people, is it really, am I being too sensitive? You know, you don't want to be seen as the weakest link, as we see that more people that are in medicine, you know, that participated in surveys and also maybe joining are more females than anything. And I would just like maybe just, you know, just maybe a closing word from Liesel. You know, how do I go back to work tomorrow knowing that my consultant is a narcissist, is a bully, is ticking all the boxes that you spoke about? How do I, just something to cope in the meantime while trying to find, you know, a way of getting there? I'm not sure if Liesel, you can just help us there.
I think it's important to understand, you know, what is happening and how to react to that. I think there are different ways of reporting and different ways of coping. I think one of the, what you've pointed out, you know, that many of the respondents indicated that they actually sought out therapeutic assistance and help and counseling. And that is one of the themes that has actually come out from the study as well, where they're suggesting that there should be counseling or debriefing for people. I think it's to really, there's strength in numbers, to talk to your peers, because if one is going through this, there are others that are going through it as well. To really establish a supportive network for yourself, to talk to peers and to really find a way of debriefing through this. This is, if it has happened, it's going to happen again. It's not something that's going to stop, especially if people are not having that self-awareness and introspection, as Dr. Flavius also mentioned. So it's a process. And I think that is what people need to understand. It's important to find your networks that will be safe and supportive. The workplace is unfortunately sometimes a very violent place. And one needs to look for psychological safety where you can debrief and be comfortable. So find your safe space in your safe network, and be there in the meantime, and find some help outside if that's possible. If EAP, unfortunately, Dr. Zolelo's experience has not been too good. If EAP is not the place for you, which sometimes happens, unfortunately, find somewhere external where you can depress and actually get to a better space of coping.
Thank you so much, Liesel. I think maybe, you know, guys, we are very fortunate to have the Dean of UKZN. I'm sort of envious for all the registrars at UKZN because, like, you know, Prof. Rosa's, yeah, like, yeah, if there's anything, email me. You know, she has just said that as registrars at UKZN, they'll be having these programs, mentoring programs every 2 months. And, you know, that's where to raise these platforms. So we're thankful for that support structure. Just, I think, a last question to Dr. Sinkubuke. One question came up. Is it possible to open an active electronic page to report and follow up complaints and to continue this conversation? I think you touched on the feedback mechanism, but I'm not sure if maybe Wandile is speaking more on just other stuff that people can bring up.
Okay, Wandile, it's there already. As I was saying to our registrars, we have had an incredible transformation drive at the CMSA, and so that and so if you go to our website, you can report anything, whether it's being bullied during the exam, and you know, whatever it is, you can. We already have that particular platform, and we encourage, please, all our registrars to use it.
Thank you so much, Nkaya. I'm allowed to say that now. I'm not sure, Dr. Nyati, if you'd like to say just some closing remarks.
Thank you, Dr. Miller. I really don't have much to say. I think as a host, all I had to do was to just make sure that, you know, I create a safe space for some of these discussions to take place. For me, obviously, I'm in business, I'm in private practice, and so I don't really deal with these matters, you know, in my day-to-day life. However, we all need to create safe spaces to help those who are coming, behind us. And so that's the little I'm trying to do. And I hope that from this discussion, we'll be able to now also look at, concrete solutions, looking at what's happening worldwide. I mean, there's a study that I looked at from Nature Medical, and it talks about the importance of people understanding, whether this is bullying or not. Number two, it talks about the importance of policies and reporting procedures in organizations. Number three, it talks about, disciplinary action, informal with mediation, and if that doesn't work, formal and with sanctions that actually, are in line with the transgression. But others, they even have ombuds, within universities or institutions, ombuds who don't report to the executive so that they are able to deal with issues, even if the bully is one of the top people within the executives. Other countries like France, they've come up with a law that actually outlaws bullying. And on paper, it looks very good, but the reports that are coming through there are still saying the reality on ground is different. So I think, there's a couple of things we can learn. I mean, this article from the Nature magazine, which is looking at this thing, across the world, Sweden and other places. There's a lot that we in South Africa can learn from what has been, reported in that article. And I hope, people can, this is an article that came out last week. So I hope people can be able to look at such articles because they give a clear way forward. But otherwise, thank you very much for everybody who joined. I hope you found these 2 hours of engagement useful. It's a pity that we don't have enough time for us to answer all of the questions, but we have to start somewhere. Thank you very much.
Thank you so much. Just literally like 15 seconds, 30 seconds to our 2 doctors that had their testaments. How, like, I'm this doctor, I've been watching this podcast. I know tomorrow it's going to be ward round. I spent 2 hours listening to this while I should be studying for something, and I might not know it in the ward round tomorrow. Like, what can you say to that person that's experiencing that? Just to the 2 doctors, Dr. Dube and Dr. Sefumba, literally 15 seconds.
I hope that everyone that's watching is introspecting right now. And to that doctor, I say tomorrow, if you still experience any kind of bullying, any kind of belittling, the most important thing that you can take away from this is that you can report it to somebody. You should not accept that kind of behavior. You've learned something new today and you need to use all the platforms that are given to you. And I really, really hope that us as consultants are walking away from this and looking at ourselves and the ways that we treat everybody around us.
So my comment, I mean, I would definitely say speak out. And I'm saying this, and even though I've had really bad experiences in speaking out, I think it's always better to tell somebody what's going on, It's always better. And, maybe a lot of them won't listen to you, but I think when you've decided to speak out, get a support system around you, because it could get rough. It could get very rough, So it's just, I find it difficult to tell people to speak out as well, because I'm just like, you really don't know what's going to happen in their situation. You don't know how bad things are. You don't know this doctor that we're telling you to speak out against. So sometimes it isn't safe, and you really need to watch who you tell. For instance, don't tell HR. Don't do it. But yeah, just be very strategic about who you tell and get like a support network around you once you've started, speaking, because it could get quite rough, Yeah.
Thank you so much. I mean, Yo, guys, there's just a lot one is taking out. But most importantly, thank you so much for every participant that has joined. We had more than 400 people, that were lined up. And thank you for taking your time. It's very valuable. And this is not the end. We can promise you that as PHS, as we advocate for wellness in the workspace, we will do our best to bring it to the stakeholders and have more in conversations like this. And hopefully the next time we'll have more practical solutions and what you can do. Just something of note is that this podcast will be available for someone that has missed it on the Dr. Fundi channel on YouTube and also just on Facebook. You'll be able to access it. I've just put out a number for anyone who needs that, they need to talk to someone. There's healthcare workers care network. So they're able to, to have just some psychologists and some people just speak to you. And I think they give up to 5 free sessions, free 1-hour sessions. So, just something to look out for, like the little that we're doing to get to, getting this monster out of the institution. But thank you so much. Siyabulela, siyabonga, bayadanki, and goeienaand. Being of Stellies, I need to put that Afrikaans in there. Hey? But yeah, musuko buhle, and have a good night, everybody. Thank you once again.
Wow.